topic that in gut is diseases of the retroperitoneal space. That is
Yes.
what Dr. John has taken us through. I'll request for any inputs, if there are any from the members, before we make general comments. So maybe to be organized, we can just go one by one. Dr. Abubakar, do you have any comments to the presentation?
Good morning, Professor, and good morning, Dr. Sebastian and colleague.
Yes, morning.
It was a good presentation, but I don't have any more questions, so I have understood more. Thank you very much.
Thank you. Thank you. Dr. Tony, do you have any? Seem to be responding. I don't know. Dr. John, do you have any comments?
No, doctor. I don't have.
Okay, thank you. Do we have any other people online? I can only see Tony and... Okay, so let me make some general comments to the presentation.
Doctor, you are muted. We cannot hear you.
Thank you, thank you. Yeah. So today we are talking about retroperitoneal disease. And to start with, we all know the peritoneum per se, a thin lining made of mesothelial cells, and it is derived from the mesoderm embryologically. And the peritoneum is a very thin layer of mesothelial cells, but it is supported by a fibrous layer, and it is divided into the visceral peritoneum and the parietal peritoneum. So as the presenter told us about the retroperitoneal space, this is the space that lies between the parietal peritoneum and the posterior abdominal wall. So that region forms what we call the retroperitoneal space. Functionally, the retroperitoneum, it acts as a medium for absorption of fluid. It is actually stated that over 500 mils of fluids are absorbed every hour across the peritoneum. So it is a medium it's a conduit for absorption of fluid. It is a conduit for blood vessels, lymphatics, and nerves. It also provides protection to the organs. Even the retroperitoneal organs are protected by the peritoneum. So if there is an abnormality in the retroperitoneal space, it may hamper these functions of the peritoneum, and the presenters try to pinpoint to some of these malfunctions that occur. But would like to go back to strictly looking into the retroperitoneal space and the organs that are located there. If you go back into your embryology again, you'll be able to determine that some organs are primarily retroperitoneal and the other organs are secondarily retroperitoneal. The primary retroperitoneal organs, these are organs which primarily develop in the retroperitoneal space. And then we have the secondary, for example, the kidneys. The kidneys are primarily retroperitoneal. The abdominal aorta is primarily retroperitoneal. The inferior vena cava is primarily retroperitoneal. But then you have other organs which develop first as intraperitoneal organs and then migrate to the retroperitoneal space. For example, the ascending and descending colon, and then the middle part of the duodenum. But this is important because it has an impact on the blood supply for these organs. So if you read about the blood supply of the duodenum, you read about the blood supply of the ascending and descending colon, you said will come from the mesenteric vessels, which are intraperitoneal. So they maintain that connection of their blood supply, despite that they are retroperitoneal organs, but they migrated from the intraperitoneal space to the retroperitoneal space. So, but also you can further divide the retroperitoneal space into a perirenal space, an anterior pararenal, and then the posterior pararenal space. I will ask you to look at these so that you understand what they are. They definitely have surgical implications if you are going to operate in these spaces. But I will also speak about the other zones of the retroperitoneum. We have zone 1, we have zone 2, and then we have zone 3. Zone 1 is the central retroperitoneum, and this one has the aorta, it has the IVC, it has the pancreas, and it also has the duodenum. It also has parts of the esophagus. And then zone 2 has the kidneys are located in zone 2. And then the iliacs, the common iliacs are located in zone 3. And these are important in case of trauma. Actually, when we talk about trauma to these organs, we define this trauma in terms of those zones. So there are two divisions here that you must mark when you talk about the retroperitoneal space. Either you define them as pararenal, anterior perirenal, anterior pararenal, or posterior pararenal, or you define according to the zones. Now, for the structural diseases, like the presenters told us about the neoplasms or tumors, okay, we use the pararenal, anterior pararenal, or posterior pararenal locations. And in some of the, like if you do CT scans, you'll be able to see those zones very clearly because they use the kidney as a landmark. But when you talk about trauma or hemorrhage, when you talk about trauma or hemorrhage in the retroperitoneal space, then we use the zonal classifications. That is what is agreed upon as a standard. So the presenter took her through the different structures which are located in the retroperitoneal zones. So it is important that you, and you also gave us the other, comparison of the intraperitoneal organs, because as he said that at times there's a confusion. We forget that that maybe an organ is intraperitoneal or retroperitoneal. Okay. So, but that is important to guide you, that you know where the organ is located. And that location has an implication on accessibility in terms of disease and approach in terms of surgery. So the presenter took us through the different conditions which can affect the retroperitoneal regions, and he began with infections, talking about the psoas abscesses, which are relatively common, I would say. But the instance of these psoas has gone down a bit, I would say. I don't see many psoas abscesses as I used to do in the past. But it also depends on the areas where you work. I don't think this is the same picture around the country. But I think in my observation, I don't see many psoas abscesses as I used to see in the past. But they will present with all the features of infection, as the presenter told us, with abdominal pain, which is localized in the lower quadrants. And usually the patients have this hip flexion deformity with a medial rotation. That is because of relaxation of the muscle, which could, most cases are pyogenic, according to what I have seen. But they can also be tuberculous. And that's why once we take that sample of the abscess, we have to send it to the lab for a gram stain and a ZN stain for rule out tuberculosis. But they respond very well to drainage. I don't usually use drains, as the presenter mentioned. I usually prefer to pack, leave the wound as wide as open as possible for proper drainage, and then spontaneous healing, like an abscess heals. And then the presenter talked about retroperitoneal fibrosis, which is, I've seen a few cases of this, retroperitoneal fibrosis. And in some cases, we don't know exactly what is the primary lesion, what is the cause. As the presenter mentioned, that some drugs cause retroperitoneal fibrosis. And one of the commonest drugs that we use are the beta blockers, which we use very commonly. The other drugs, hydralazine is one of them, but well, the use of hydralazine is not so common now. Then we have seen patients who have chronic obstruction of the ureters, maybe following a C-section. Some of these patients tend to develop retroperitoneal fibrosis. Although usually by the time we intervene to operate them, we usually operate them during the camps, maybe within 1 to 3 years, the fibrosis has not spread so much. But this is one of the other reasons that we have seen retroperitoneal fibrosis, chronic obstruction of the ureters following either ligation during C-sections or during gynecological operations. And what we do usually is freeing the ureter and reimplanting it into the bladder. And then we presume that the process resolves once the urine begins flowing normally as it is supposed to flow. You will find some patients who have had urinary diversions. There are not so many in the country, but again, there are patients who have had urinary diversion for one reason or another, maybe due to a malignancy, patients who have had bladder resections due to cancers of the bladder, and they have had a diversion of the ureters into the colon or into the ileum. Again, some of these patients who have had very severe bladder injuries that the fistulae cannot be repaired, we have an option of diverting the ureters into the sigmoid colon. But the problem that we see is retroperitoneal fibrosis after these diversions. That's one of the complications. Now, the treatment definitely, once you find these diversions, is taking a biopsy to confirm that is fibrosis, and also relieving the obstruction. If it is a ureter, relieve the obstruction. If it is the gut has been trapped, relieve the obstruction so that there is no more physiological function. The presenter has taken us through the tumors and sarcomas, as he mentioned, are very common. Lymphomas. I have had one patient with a gastrointestinal stromal tumor at Mubende, a 66-year-old man who is hypertensive and diabetic, was referred to actually sent to me in the private wing at Mubende, and he had this abdominal mass, which was rapidly increasing in size. He had pain, which was present all the time, and it worsened when he was lying in bed. So he preferred to be sitting most of the time. He had loss of appetite, and he had noted weight loss. By then he had had these symptoms for like 3 months. So we sent him to get an ultrasound, and the ultrasound talked about a lesion in the pancreas. And then I advised him to get an abdominal CT, and the CT scan mentioned a tumor which was involving the pancreas and also the left adrenal gland. It was 12 centimeters by 15 centimeters, and that was quite a large tumor. So looking at his condition, his state, his age, his comorbidities, having such a complex tumor, I referred him to the colleagues in Mulago, and then he repeated another CT scan, which talked about a primarily pancreatic tumor. So because of this complex picture and varying findings on the CTs, the team decided to perform a laparotomy, and then they found this huge tumor, retroperitoneal tumor, which was located in the pancreatic region, and it was involving parts of the stomach. So the patient had a partial gastrectomy and plus total excision of the tumor. And the pathological findings indicated no malignant transformations. So the patient had a review CT scan 1 year later, and no new lesions have grown, but he's being followed up by the Uganda Cancer Institute for any recurrences. But so far he's doing all right. So this is the patient I can say. It is not so far away. It is about 2 years ago since, and he usually comes to Mubende anyway to see me. So, but he's a patient that I truly recall has a gastrointestinal tumor, and that is a good example of what we're talking about today when we speak about retroperitoneal tumors. A number of them that you will see, you'll find secondary tumors in the retroperitoneum. You may find some of these retroperitoneal tumors. The only challenge is that in most cases, these tumors present late, as one of the pictures that the presenter showed us, the tumor pushing almost all viscera to one side of the abdomen. And depending on the economic capacity, patients may not be able to afford other investigations. And also management may become complicated. If you have patients who have comorbidities, you don't only think about the surgical intervention, you also think about the post-operative care. This patient I'm telling you about had to spend 2 weeks in the ICU in Mulago. So if he didn't have an ICU with these problems of blood pressure and problems of diabetes, it would have been very, very difficult to manage him in the post-operative period. So the management will depend on your capacity to manage to offer the surgery and also manage the postoperative period. But most of these tumors have to be excised and subsequently offer them chemotherapy or some non-inflammatory suppressing agents, steroids, and others. Now, I would like to end my comments with trauma in the retroperitoneal space. It could be trauma, it could be a ruptured aneurysm. We have also seen patients with hemorrhagic pancreatitis almost also presenting with similar pictures like this. And this is something that you'll definitely interface with. It will come to an emergency situation. The patient has been involved in a road traffic crash, has a ruptured duodenum, has maybe a ruptured iliac vessel, has a renal injury. Renal injuries are very common. You'll get them. Recently we had I don't know whether you had come, when we had a girl who was stabbed in the back into the kidneys. I had a boy who was crushed by a car and had a very bad renal injury. Now, the challenge with retroperitoneal injuries is access to the organs. If you're not really acquainted with retroperitoneal surgery, it can be very, very challenging. And that's why I thought of giving you a few tips on this. So there are two approaches that we use to access the retroperitoneum, and one of them is the Churchill brush maneuver, and the other one is the Mattox maneuver. The Churchill brush is very good for, both of these will help you to move to reflect the organs medially so that you can easily access the retroperitoneal organs. Now, for the Churchill brush, it is what we use to mobilize on the right side. And this one involves opening of the right hepatic flexure. So you all see where the right hepatic flexure is. That is the reflection of the ascending colon towards as it goes into the, becomes the transverse colon. That angle is called the right hepatic flexure. So you free that right hepatic flexure and you go further down. Further down, you'll find that white line, which we call the theodate line. And then you dissect through that white line and you come to the junction of the mesentery and the retroperitoneum. So you open that point, and once you open it, you can now freely move all those organs, the ascending colon, and further down. You can do a very clean dissection so that you can access the right kidney, the renal, right renal artery. You can access the inferior vena cava. You can access the right iliacs through that approach. If you don't use that approach, it will be very difficult for you to dissect. Like you cannot open the whole mesentery. There are so many vessels there, and you cannot keep ligating and ligating and dissecting them. You are going to cause necrosis and gangrene of bowel and other structures, and also chances of injury to the right testicular artery, to the iliacs is very, very high. Injury to the thoracic duct is very, very high. So, but that shuttle brush maneuver enables you to access the organs on the right side. Then the Mattox procedure, you open the splenorenal ligament, and then you go down into the retroperitoneal space via that angle. Actually, at times I use it if I'm doing splenectomies. I go through there, and then I can freely mobilize the spleen, both the other side and this side. So that Mattox maneuver will enable you to dissect into the retroperitoneal space, and this is very good for exposing the anterior part of the aorta. If you have a patient who suspects a ruptured aneurysm, always remember that point, the splenorenal ligament. Open that area, and then you go into the retroperitoneal space. So you can really come further down, expose the anterior aorta. You can formerly we used to move the right kidney. Like if you have a kidney renal injury, you access it through that point, and then you can access the kidneys properly. In the old previous or the de novo Mattox, it involved moving the left kidney as well. But now in the modified type, the kidney remains sitting in that gyrotous fascia, and then you move the other organs medially. It is less invasive, and even for someone who is not experienced, you can easily do this maneuver and you access the anterior aorta. But these are two techniques that I really like you to have. You never know in the middle of the night when you'll be called and you'll find this sort of patient. I think the first time I applied the shuttle was when I had a patient with a duodenal injury. And it is very difficult to access the duodenum unless you use this sort of maneuver. That's why I like you to, wherever you do laparotomy, don't go only to clean out, maybe if it is a perforation or it is a ruptured peptic ulcer, or you are doing a sigmoid resection. Wherever you do laparotomy, take a chance to look at these 2 points and say, I may have to come back here for another procedure, just to help you be acquainted with these two anatomical positions and the importance that they are in terms of managing some of the conditions. I wish to end my submissions here for today. You'll have time to go over the other basics on the literature. Today being a Friday, I think we shall take a break, and then we shall resume our lectures on Monday when we talk about management of esophageal cancer. Then on Tuesday, if Sebastian can be able to prepare, we shall talk about management of intestinal obstruction. And on Wednesday, if Sebastian can again be able to prepare, we talk about surgical management of ulcerative colitis. And we shall end on Thursday next week if we can still have the topics prepared.